Hohman, Vice President of Friends of Cancer Research. I want to extend an incredible thank you to our partners at Provision Policy, Ramsey, Kate, Michael, Cole, Laura. You're all not only incredible partners in this endeavor each year, but also some of the most brilliant analysts on some of the most complex policy issues there are. I also want to thank the staff of Friends of Cancer Research, including our CEO, Jeff Allen, our founder, Ellen Siegel, and our outstanding public affairs leads, Lexi Turbo and Joe Patterson. I'm very pleased to have the opportunity to introduce Administrator Seema Verma for today's keynote address. Yesterday, Friends of Cancer Research held our 11th annual meeting. While we focused on the FDA, CMS and NIH were ever present throughout the conversations throughout the day. That's a testament to the collaborative leadership of Director Collins, Commissioner Gottlieb, and of course, Administrator Verma. Since today's conference is all about the intersection of CMS and FDA, I wanted to share a few words that Administrator Verma shared just last month here in Washington. Administrator Verma said, quote, "While FDA has been accelerating the introduction of generic and biosimilar products, CMS has been acting in concert to modernize our payment policies to increase competition, because at CMS, empowering patients and increasing choices are driving factors in virtually every area we oversee. Because when patients have choices, cost and quality improve." And that resonates very well with this conference. As the 15th administrator of the Center for Medicare and Medicaid Services, Seema Verma oversees a $1 trillion budget, 26% of the total federal budget, and administers healthcare programs for more than 130 million Americans. As administrator already, Verma has set goals for digital health information that will empower patients and transform healthcare. She's updated documentation guidelines to reduce administrative paperwork through the Patients Over Paperwork initiative. She has also advanced new alternative bundled payment methods to motivate providers to furnish services more efficiently, coordinate care better, and improve quality. And lastly, at Friends of Cancer Research, we applaud the important work she has done regarding next-generation sequencing. Just another acknowledgement of how this agency is pushing the best science for patients. So please join me in welcoming Administrator Verma. We are honored to have her with us today and grateful for her service to our country and to patients.
Good afternoon, and thank you for having me today. I did want to start by just taking a moment to remember Dan Best, who served as Secretary Azar's Senior Advisor for Drug Pricing Reform. And for those of you who had the privilege of getting to know Dan, you know that he brought tremendous energy and passion to his role. And I'm grateful to have had the opportunity to work with him. We miss Dan, and we're keeping him and his family in our thoughts and prayers. Well, I'm glad that you all are eating lunch, because I think it's going to make this speech far more entertaining than just having to listen to me speak. So I'm glad you have something to do as well. So from day one, President Trump has made it clear that lowering prescription drug costs is one of his top priorities. And in May, the president released the historic American Patients First Blueprint, which was the most sweeping set of policies to lower drug prices ever proposed by an administration. And CMS has been hard at work to make the President and Secretary Azar's vision a reality. Because the status quo is simply unacceptable. And as Secretary Azar has said, there is little difference for a sick patient between a miracle cure that hasn't been discovered and one that is too expensive to use. Drug pricing is a particularly acute issue for CMS. Combined, Medicare and Medicaid represent 40% of the United States drug market, and we are the largest purchaser of prescription drugs on the planet. And even if you just look at Medicare, it's clear that our spending is growing. In 2012, Medicare spent 17% of its total budget, or $109 billion, on prescription drugs. And 4 years later, in 2016, this had increased to 23%, or $173 billion. So we're talking about an increase of $64 billion in just 4 years. So I'm excited today to discuss our approach to transforming the way Medicare pays for drugs in two of its main programs, Part B and Part D. Part B covers physician-administered drugs through a fee-for-service system, and Part D covers drugs that are picked up at a pharmacy through private plans, as you all well know. And we were honored to have President Trump come to HHS recently, the first visit by a president to the department in over 10 years. President Trump came to announce the International Pricing Index model for Part B. So I'm going to spend my time today unpacking that model. In Part B, Medicare pays doctors for physician-administered drugs at an amount equal to the sales price of the drug plus a percentage-based add-on fee. And Medicare is simply a price taker for these drugs. There's no competition and no negotiation. Now in the Part D program, negotiation brings discounts on the order of 20% or more. And in Medicaid, drug discounts are guaranteed in statute, and there's additional savings that are negotiated by states. But in Medicare Part B, by law, we pay the average sales price for a drug, whatever that price may be. And this is a prime example of the kind of misaligned incentives that we see throughout the Medicare program, and why I have concerns about Medicare for all. As drug prices continue to rise, accepting the sales price is not sustainable for the millions who depend on Part B, and the number of our Medicare enrollees is projected to grow by 16 million in the next 10 years. So that means we're going to go from 53 million enrollees today to 69 million in 2027. So the problem is particularly serious when you think of the new gene therapies coming on the market, many that will be physician administered, with prices approaching $500,000 or even $1 million or more dollars. I think I just read an article about some new drugs for MS that may be priced at $1 million to $2 million. These price tags could not have been imagined when the Part B program was designed. And it's our job to protect and strengthen the Medicare program so that all Americans, once they become eligible, can benefit from the latest science. And we can't let high-priced drugs jeopardize the promise of the entire program. So in response to these issues, the IPI model offers a fair and sustainable approach to drug payment in Part B, because it's time for Medicare to be a smarter purchaser. Our nation depends on it. The model was developed with several goals in mind: lowering costs for beneficiaries, introducing competition into the system, reducing burden for physicians while maintaining their financial stability, and addressing the disparity in drug prices between the United States and other countries. Under the new model, Medicare would slowly phase in a payment level based on international prices. And why? Because other developed countries see far lower prices for these drugs than we do, even though Medicare is the single largest purchaser of these drugs. And this defies common sense. In what other market does the largest buyer see the highest prices? The pharmaceutical companies have chosen to offer prices abroad that are substantially lower than what Medicare pays and what our seniors, people living on fixed incomes, are forced to pay. The IPI model would generate savings of 30% for beneficiaries and for taxpayers. So a savings of up to $17.2 billion over 5 years. And beneficiaries would potentially see lower Part B and Medigap premiums and lower cost sharing on the order of $3.4 billion. So that could mean that a senior receiving a medicine that costs Medicare today about $1,800 a month, but costs other countries just $300 a month, so they would see their annual coinsurance drop from $4,400 a year to just $900 a year. That's real savings. Savings would be driven by the fact that the average amount that Medicare pays for some of the most expensive Part B drugs would phase down. And payments would decrease from a level that is about 80% above average international prices today down to about 26% above international prices over 5 years. And as I mentioned, the goal of the IPI model is to maintain financial stability for physicians, essentially to keep doctors whole. And contrary to the information being put out by some stakeholders, instead of basing physician payment on the price of a drug, physicians would receive a fixed payment amount. And that payment amount could vary by physician specialty, physician practice, drug class, or some other variable. And we're open to input. We're working with physicians on this. But the idea here is to remove any appearance of an incentive for doctors to prescribe higher priced drugs and for manufacturers to set higher prices. Patients would simply receive the most appropriate drug for their clinical condition, and we would pay doctors for administering and handling the product. And another plus is that this change would encourage the uptake of lower cost biosimilars, which have been slower to take hold in the American market than overseas. And so by paying doctors to cover the cost to handle drugs without linking payment to drug prices. An increase in the total amount of funding available for add-on payments is designed to protect financial stability for physicians. The pool of funds available for add-on payments would be 6% of prior year spending on Part B drugs, as opposed to just 4.3% of average sale price, which is what it is today. So this would result in an additional $1.3 billion in add-on payments for doctors over 5 years. And I'm going to repeat that because I know that there are some groups that are putting out information that's saying that doctors will lose money. This is an additional $1.3 billion for doctors over 5 years. And reducing the burden on physicians is also our goal. We've heard from physicians that taking on the financial responsibility for Part B drugs, which are expensive and fragile medicines, can be challenging, especially for our providers in smaller practices. And our Patients Over Paperwork initiative makes clear that we want physicians to be able to focus on providing high-quality care for their patients, and we're committed to addressing the administrative burdens that they face. And therefore, the IPI model shifts the responsibility of holding title to Part B drugs to vendors that physicians are already working with who are better equipped to deal with this. And those vendors would bill Medicare for the cost of the drug. And this is not unlike how the 340B program works today. The vendors that we're talking about might be specialty pharmacies, distributors, or even physician practices. And we're looking forward to working with physicians and distributors on ways to structure this to ensure the success of the model. There are no two ways about it. The IPI model is a significant change. It's an overhaul of Medicare Part B drug pricing. And that's why we've taken the extra step of soliciting input by issuing an advance notice of proposed rulemaking. And the input that we receive will inform the development of a proposed rule early next year. So our goal is that the model will be mandatory for half of the country's providers. And while we will seek input on the methodology for selecting the geographies, randomization will likely be needed to ensure a valid comparison group. The IPI model would, for the very first time, introduce competition in Medicare Part B. Now in Part D, private plans are already negotiating with manufacturers, and plans are keeping premiums down. Part D premiums decreased this year and are projected to decline again next year. And Part D has been a success because instead of a government bureaucracy making decisions for patients, the Part D program protects a patient's ability to choose the plan that's right for them. Beneficiaries know which drugs are covered in a particular plan, the premium, and the level of cost sharing. And so the patient can choose the plan that meets their needs. And they can make trade-offs between cost and quality. The important thing is that they are making the decision, not the government. Part D is a market-based system where prescription drug plans are competing for beneficiaries. And in a market system, competitors must provide the highest quality at the lowest cost to attract customers. But when the government controls the process and only offers one option with no choices, the push to excel or go out of business is no longer there. And so as we look to the future of Part D, we must move to an even more dynamic and competitive market, which will lower prices while protecting patient choice. And CMS intends to give Part D plans more leverage in their negotiations and more flexibility in their benefit design so that they can continue to drive towards lower costs and higher quality for our beneficiaries. I want Part D plans to have every tool that plans in the commercial market have to lower costs, increase quality, and promote transparency, including at the point of prescribing. And we have seen innovative approaches emerge in the private sector to provide real-time cost information to patients and providers. And one area in which our Part D plans are more constrained is in their negotiation and their negotiating power for drugs that are in the so-called protected classes. These are therapeutic classes for which Part D plans have to cover essentially all the products that are available. And this administration is committed to ensuring that seniors are getting the best deal possible in all therapeutic classes, including the protected classes. Private plans are able to ensure access to drugs in these categories while also negotiating with drug manufacturers for the best deal. And today there are more competitor drugs in these classes, including generic drugs, than there were when the protected class policy was created. Typical private market discounts for these drugs are in the order of 20 to 30%. But the average discount across all protected classes in Medicare Part D is just 6%. It's important to lower costs for all patients, including patients who need the drugs in protected classes. And one of the successes of Part D plans has been their encouragement of generic drug utilization over the years. And most of you in this room are aware that around 90% of all prescriptions filled in the United States are for generic drugs. Pretty remarkable. And earlier this year, we finalized a rule that allows plans to substitute generic drugs for branded drugs more quickly on formularies so that beneficiaries can access low-cost generics as soon as they're approved. And when it comes to empowering Part D plans to encourage generic utilization, we're not leaving any stone unturned, and we're looking for ways to save money for our beneficiaries. In 2016, Part D beneficiaries spent over $1.1 billion in out-of-pocket expenses for branded drugs that had comparable generics. Clearly, there are savings for patients being left on the table. And so to this end, CMS issued a memo to Part D plans this summer explaining the tools that they already have available and our expectation that beneficiaries are getting the best deal possible. And while the memo reminded plans of their current authority, we recognize that additional barriers stand in the way of fully encouraging generic utilization. So stay tuned for more from us on this. And other policy changes that I want to highlight include removing what was called the meaningful difference requirement, which restricted plans for offering more choices of plans to seniors. Well, we've removed that, and we saw an immediate uptick in the number of Part D plans by over 15% in just the first year. So with more plans, we have more competition and lower prices for our beneficiaries. And we've also introduced flexibilities that Part D plans will be able to leverage in the future. So currently, if a Part D plan includes a particular drug on its formulary, the plan must cover that drug for every FDA-approved indication or patient condition, even if there are other drugs that are more effective for a given indication. The requirement to cover drugs for all indications actually discourages Part D plans from including more drugs on their formulary. And so we've announced that starting in 2020, plans can tailor their formularies so that they can cover drugs by indication. And this policy will provide beneficiaries with more drug choices, as plans will be able to cover the most appropriate drug for every condition. And we announced the change this year so that plans have time to incorporate this flexibility into their negotiations with manufacturers prior to the 2020 plan year. And Part D plans have done a great job in keeping premiums low. However, while plans can be a powerful negotiator, sometimes it's the case that a plan's incentives are not completely aligned with the patient's. And one practice that some plans have used, which I find completely unacceptable, is the imposition of gag clauses. And this is essentially not allowing pharmacies to tell their patients about how they may get that same drug at a lower cost, maybe buying that drug outside of their insurance plan. And so over the summer, we sent a letter to Part D plans explaining that any form of a gag clause is contrary to CMS's efforts to promote drug price transparency and lower drug prices. And thanks to President Trump and bipartisan leadership in Congress, gag clauses are now illegal. And I was honored to be at the White House recently for the signing of 2 bills to end the practice. And so now, pharmacists can help their patients find the best deal on prescription drugs. And the drumbeat continues. CMS also recently proposed to require that manufacturers post their list prices for drugs in direct-to-consumer ads. Patients often pay their cost-sharing or deductible off of a drug's list price, and so this requirement would inject greater transparency into the prices that manufacturers set. So essentially, if somebody's watching TV, we all see those ads, they would have to put the list price in the ad. Well, thank you for having me today as I've walked through the major drug pricing initiatives in Medicare. But I would be remiss if I didn't also mention at least one significant example of our work to lower drug costs in the Medicaid program. And I'm honored to announce that today CMS is approving a proposal from the state of Michigan to enable the state's Medicaid program to enter into value-based payment arrangements with drug manufacturers. This is the second proposal of its kind that CMS has approved, following a similar waiver from Oklahoma this summer. And Michigan's waiver will empower the state to demand results from drug manufacturers in exchange for paying for medicines. And I applaud Michigan's proposal. As we see innovation in biomedicine, it's incumbent on us to also modernize payment policies. And we've heard that the industry is very interested in value-based payment. And new payment arrangements are needed and could take various forms, including drug payments over time, only if the patient achieves certain clinical outcomes, drug payments through a shared savings approach based on the drug's impact on a patient's total cost of care, or it could be payments under a subscription approach, with an upfront fee in exchange for as many doses as clinically necessary. Value-based payment is not a panacea, but it is an important part of our strategy to lower drug prices. All of our initiatives are ambitious, but we're not stopping here. You should expect more from us in the coming weeks and months, and as we continue to execute on the President's blueprint, including to encourage value-based purchasing. And we look forward to your input, because together we can ensure that all Americans benefit from the advancements in 21st century biomedicine. Thank you very much for your time today.
Thank you, Administrator Verma. We really appreciate your time today. Enjoy the rest of your lunch, and we'll be moving back next door very briefly. Thank you.